This is really going to be a unique platform. People will be able to tune in and see interventional live cardiology cases from around the world performed by some of the world's best operators. The real advantage of this is that they'll do 9,000 cases spanning the whole spectrum of interventional cardiology.
For Medstream 360, we'll be extending 24-hour live cases so that you can watch cases in your own time zone, time frame, at your own convenience.
Medstream 360 is a transformation in medical education. With Medstream 360, you can see wherever you are, in your office, at home, in your computer, in your iPhone or your laptop or your iPad, any case in any topic whenever you want. And not only that, you'll be able to see the best operators from around the world sharing their live cases with you.
There are several unique attributes of Medstream 360. We have no moderation and there is no time restriction. The majority of the cases, an overwhelming majority of the cases, are viewed not live but archived cases. So to enhance your viewing experience and to customize the archived cases to your requirement, we have assembled an army of physician video editors who have been experimenting with different formats. All of this is being done to enhance your experience and to make Medstream the most beneficial.
Concept here is to provide easy access to more live demonstration cases to more physicians. I think live demonstration cases are probably the best way to learn the nuances of our field. And the more we can do to bring cases of interest to our community, the better we'll all be. This is a great way to exchange information and to keep up with the latest in interventional cardiology, period.
So I look forward to welcoming you to Medstream 360, and please give us your feedback. We hope you enjoy it as much as we're enjoying putting it together. Thanks very much.
Today, Los Robles is a licensed 382-bed hospital with additional campuses such as Thousand Oaks Surgical Hospital, our Rehabilitation Hospital, Moore Park Imaging Center, the Center for Advanced Wound Healing, and the Cardiovascular Institute of Los Robles.
Okay. Hi, guys. Nice to see you. We're just putting in a catheter into the left atrial, and then I'm just going to talk to you right now. Hold pressure. Just hold pressure. All right. Just give me a pressure line. Once again, thank you very much from people from Medstream and Samir for allowing us to present this case. And I would like to introduce our team first. We are from Los Robles Hospital. I start by introducing Andrew Gabriel. Andrew Gabriel is cardiac anesthesia. He's behind the screen. Give him a big clap because he's actually the anesthesiologist and the echocardiographer.
Hi, guys. Good to see you.
This is Gabe Oreda. He's actually the chief tech, and he's actually going to help out in the case. Then we have Dylan, who we found on this road. He's a intern in anesthesia, and he wants to do a live case with me. So he did the transeptal, and he's all set to help out. Then we have Colleen Shell, one of the techs who's been working for a long time with us. And then you have Pierre from Abbott. You have Kathy, who's sitting there monitoring, and you have Jose. Where's Jose? I don't see him. Jose, he's on one of the lead nurses over here. He only speaks his single language and only Spanish. That's the problem with us. And I would like to start the case. And so we also have in the room Laura. Laura is actually one of the first-year residents who's going to present the case. So Laura, do you want to start presenting?
Sure. So I'm just the patient here is a 76-year-old male with recent CHF exacerbation. So he has pretty severe heart failure with preserved ejection fraction. His class 3. So he has pretty severe symptoms. He was past medical history of hypertension, type 2 diabetes, permanent atrial fibrillation, chronic kidney disease, and thalassemia minor. He lives alone, and he uses a cane for ambulation. He was admitted previously in March to Los Robles for exacerbation of his heart failure, and he was readmitted now due to failure of outpatient therapy. So despite Bumax outpatient and Gold medical therapy, he came back in. He has worsening heart failure due to severe mitral regurgitation, and he was considered high risk for surgery by Dr. Fontana, a cardiothoracic surgeon. So now Dr. Carr will be doing a MitraClip.
So Laura, can you just show those echo images?
Yes, I will. On to the next. There we go.
As you can see over here, there's the LV function is preserved. The left atrium is enlarged, and you can see mitral regurgitation is eccentric. But I didn't want to show you all the details. We're going to show live TE. This patient is in basically refractory heart failure. He has had 2 admissions in the hospital for 3 weeks with a high creatinine of 2.9 with morbid obesity. So he was considered to be extreme to high risk for open heart surgery. And I'm sure most people would consider that. But before we do anything, I'd like to, Andrew to show some of the images of the mitral valve. Andrew's an outstanding imager, and actually I would like him and everyone to get an opportunity to show you how he's actually going to show you the different images. And Laura, you can join us.
Okay. I will take off my mic.
Yeah, our most instructive image here is the mitral commissural view here. And you just put color on here. You can see a jet, the prominent jet that we're going to be going after, and see what we're left with after is this jet right here. If you look at my pointer right here on the P1 area, and the lateral aspect of the valve. And often you can underestimate this because you don't see it going up into the atrium, but it's going across the valve from the lateral to medial direction, and it is a significant jet, classified as moderate to severe at least. And if you go from here, we can go X-plane and give us an orthogonal view, and this is where kind of our grasping view will be. And you can see right there at the commissure posterior prolapse, and I wasn't really able to appreciate the color jet across in this view, but nonetheless, that is where the pathology is, and what we really want to see is what we call a Pisa jet underneath the valve, and we do see it there. And then we'll go from here. We'll go to a 3D view, the surgeon's view, looking from the left atrium down into the LV across the mitral valve. And we put the anterior leaflet on the top, posterior leaflet in the bottom there. You see the aortic valve right there. That tells us we're kind of oriented correctly. And again, we're looking from lateral on the left side to medial. And you can see this little nub in here with a torn cord there, and that's that P1 flail. And if we put color, you'll see that jet coming across from lateral to medial and directed anteriorly. So that is primarily kind of where we're going to go attack this valve from.
So, Gabriel, since you've shown me those images, can you show us a good explain image of what will be my line of, how am I going to
Grasping view, yeah.
grasping view, because I want to
Yes.
understand it, because it's actually quite challenging. It's so commissural. How do you actually grasp this leaflet? But that's not the right angle, right?
Yeah, so we're gonna, well, that's the 90 degrees, but we're gonna have to kind of decrease the angle, right?
Yeah,
Since it's so commissural.
right. I mean, you can use.
Would you like to use multi-MPR?
Yeah, use MPR. Let's see what
Okay.
happens.
All right.
So
So again, we start with that 3D image. Orient it correctly. And we hit the multi-view function. We're using a Philips machine here.
So what he's trying to do is trying to reconstruct the images. This is a very nice view, actually. The 3D on the right lower corner shows that little prolapse there.
Mhm.
You can bring the red line right over that prolapse.
Yes.
Okay. And then you're going to go, that's the midline, and now you're going to draw the red right over that commissure. And in the right lower corner, you can see you can already turn the orientation appropriately.
Yeah, so I think when we go grasp,
yes.
it's going to be like this.
Yeah.
Just kind of perpendicular to the coaptation line.
And that's where you can see the P1 flail. See
And
how
there
nice
it is, yeah. And then if you look in the top right image, and I'll maximize that so you guys can see, but that's where the flail is, and you see the torn cord flickering every now and then as well.
And put color on there. And that's the pizza. So I think you can go even more lateral. Try to bring it even more lateral with the red. And that looks even better, right? That's even a big as visa. And if you put color, yes. So I think I should try to go as lateral as possible.
Right. Yeah, but you can see this is always a cord-rich area, and so we've decided, Dr. Carr, right, to go with a narrow, short clip.
Yeah.
Yeah.
All right. So let's do one thing. So let's get can you show where the transeptal is, and we're going to get the guide in. So we have done the transeptal in the mid fossa and in posteriorly.
Mm-hmm.
We have enough height, I think. So we have two catheters across the septum. We have a pigtail catheter, which is measuring the left atrial pressure. And pull the wire, please. Pull it more. Oh, is that wire?
You have quite a bend in the wire there, Saibal. Do you see that?
I don't know why that's so bent. Okay, just bring it.
There you go. You've straightened it out. Yeah.
Yeah. Okay. Good. And then I'm just going to go slowly in.
And you can see the tip of his dilator coming across now.
And I think I may have gone in already.
Yep.
Okay, good. So the guide's inside. Okay. So let's get this.
So in the MitraClip system, you see what we call zebra lines here. And that shows us that that's the dilator. And then this is the tip of the catheter, the guide here. So he wants to make sure he has enough guide across so when he pulls out the wire
just keep it
and dilator, the guide will be in the left atrium.
You're going to just gently aspirate, very gentle, almost like gravity, like nothing. It's okay. And I'm just going to pull first so first I'm getting the dilator back, which shows that my enough guide is in.
And you see,
and I'm just going to pull back.
You see the guide there in an appropriate position there.
Okay. So Pedro, can you make sure that echo is large and fluoro, and then can they see hemo low down? Yeah, now pull hard. And you see how the left atrial pressure is severely elevated? Yeah, pull more. Yeah, good. Keep pulling.
You can see his pigtail and his guide across there.
Okay, good. And advance the blood back. Give the blood back. Good. So, guys, are you showing them the fluoro and echo on one side and with hemo on one and my hands? And you can see that the left atrial pressure is grossly elevated with a very prominent V wave. And the V wave is around 48. And this is after anesthesia, after diuresis for 4 days, IV diuresis. So he's in such bad decompensated heart failure. And we think that a contributing factor is his diastolic heart failure, obesity, as well as the MR. So if we can put this in and you just flush this forward, just flush it a little bit. He's going to flush it. So I'm going to advance the clip in. I've got the guide inside nicely. And now I'm just going to go with the clip. So the clip is going in.
You can see the clip coming up there, and it's out.
Okay, good. And now I'm just going to go flex it in.
And so you watch him here at this point trying to avoid that Coumadin ridge between the pulmonary vein and
the guide, like this, and hold
left atrial appendage. And he is hitting it there, but I think he just cleared it.
See, I'm bringing the clip down. See
Good.
that?
So now he's coming down towards the valve, and I'll go to an X-plane image. Often they're anterior in this, and that's where he is there. You can see him in the right image.
If I ask you to clockwise this like this, okay? Clockwise that. See that? I'm clockwise, okay? Counterclockwise like this, and tighten it. That's good.
Yeah,
you
great.
see the clip is going down there?
And there,
And actually the
he's right
position
in the
looks-
right position.
I think the position looks great, right?
Really good. Yep. So we'll go ahead and orient the clip. He's going to
I'm just
open
going
it
to
up.
give a little bit of, see that? We're on the lateral part, and that's where the clip is. So what I'm going to do is, I'm just going to, what's happened, boss? Gaby, you okay? You want to go to the restroom? Links. Okay. All right. So the clip is open, and you see I'm trying to look at the clip orientation. So do you want to show me?
Yep. So unfortunately, every time you kind of move this, you have to reset the image when you go back to 3D. So there we go.
Okay. So we need to go a little bit more lateral, correct?
Yep.
So lateral means I'm advancing it. See, I'm going and advancing a little lateral. And also, you see the orientation is almost perfect, but a little bit counterclockwise. See, it's a bit off. Like I want to get it like this. I want to get it like 1 and 7. See that?
Yeah.
So I'm just going like this, and I'm just. So I like that position. What do you think? So
I think it looks good.
And then I'm going to come back a little bit more, go in and more. So a little bit more lateral, because it's right in the commissure. See that? And then you see the clip wide open. And I like that position actually. And I'm just going to test the grippers now.
I think it's good, yeah. So we're focused on the right image.
So the dot is
right
posterior.
Image. Yeah.
Oh, sorry. So
That's
dot is
answer.
anterior and blue is posterior. See the grippers coming down?
Do you see that gripper in the posterior one? It did not look like it came all the way down, not as far as the anterior.
I'll show you.
Maybe cycle them a little bit. They might be a little stiff. Do you see that, Saibal?
That's okay. That's all right. Right? Yeah. I think that's okay. So do you think in color is this spot, or should I go even more lateral?
We can look.
I like the orientation very much. I think it's going to be very helpful.
Yeah, I think you're lateral enough, Saibal. You see PISA.
Okay, because remember, I want to be as lateral as possible.
Yeah, you don't want to leave anything. Yes.
I don't want to leave any gap, and then I can always put another.
You can also see the pathologies hitting your clip there too,
Yes.
right? So I think this is a good spot, Saibal.
Okay, so I'm still trying a little bit more lateral. Okay, and you actually can see the flail.
That's what I'm saying. Yeah.
So okay, I'm going to clockwise the catheter. See that? So it goes in this way. Then I'm going to close the clip. See, I'm closing the clip. See that doing? And now I'm going to advance the clip. And as I'm advancing, I'm going to see that it doesn't dive. I like that position. Maybe I can come back a little bit more. You see how it dived? I'm going to take off a little bit of lateral movement to go below, because it's tending to dive in medially. See? So taking it off a little bit. I don't think so. No? These are particularly challenging to do because it's right in the corner. And it's
below
really,
the valve
yes.
almost.
Just a little bit more. Now it's below the valve, right? And then I'm just going to open it up.
Yeah, there's a cord right under. There you go. Perfect. Don't advance anymore. That's great.
Okay. And I would just see if I can go. Can you see 3D and just see the orientation?
Yes, so we're going to focus on that bottom right image for him and gain down, decrease the tissue penetration there.
And I can clock it.
I think you can clock it a hair, yeah.
Okay, see that? The orientation, I'm just wanting to be, because it's
And
in the corner, so we wanted like 1 and 7.
And if you look at that red line, that's kind of our grasping view. So
Okay.
now it's oriented perfectly.
1 and
So
7.
I'm going to gain back up.
And then we want to go, I just have a feeling we should like to go a little bit more lateral, if possible. I know the leaflets are fallen nicely on it.
Yeah, the posterior leaflet's getting hung up a little bit on the shaft there. It's not diving it in, yeah.
I can do that. That's not a problem.
There you go.
See, now both the leaflets are on,
Yes.
right? And
Very
I can drop
nice.
the gripper. And
you have both good bounce there.
Okay.
I wonder if you could optimize posterior a little bit, don't you think? Or
I can optimize, okay?
I like anterior very much.
Yeah. So I'm going to dot is posterior. Posterior. Okay, I'm going to clockwise this catheter, and you're going to hold it for me like this. Hold it like that. Okay, good. Pulling the blue. You see how far near the annulus I am?
Mm-hmm.
And then I'm just going to pull up.
Yes.
And I've got a lot.
You got everything. Yep.
Okay.
Beautiful. Look at your orientation, the bottom left image. Do you see that?
This-
That's exactly what you wanted.
Okay. So shall we close and see what happens?
Yes. I think it's great.
And watch LA pressure if there's any change. And the LA pressure is slowly coming down.
I just
See
have
the
to
LA
say,
pressure?
the window Dr. Carr had to make it through in this one was so small, and he did it perfectly. It was really good.
And the LA pressure is coming down. Did you see that?
That's
No,
nice.
look at
Nice job.
Right? So I think I've got it. So that's beautiful. And now we have to, the insertion is great. This 3D is really, let's look at color and see if there's any change.
Yes.
Sometimes you,
Yeah. So I'll just do some assessment here.
oh yeah, the color is beautiful. You see, remember there was this horizontal jet going through. And I didn't notice there was a very tall V wave in the LA pressure lower down there. And then it came down. All right.
Perfect. Thank you.
Laura, that's the heart.
That orientation is nice.
No, I'm just silly. Actually, there are 2 residents here who have been helping me out. And this is, if I'm correct, this is your first MitraClip case. And you guys are scrubbing in. This is awesome. And we have Gabe and Colleen who are chatting behind, not stressed out. We can hear. It's very difficult working with them here. The environment is very unfavorable. And it's hostile to some extent. So I think the results good. Now people will get worried about all those vertical jets, but those aren't from a different spot, right? So I would just do.
Yeah, we want to make sure there's nothing lateral.
But and what is nice is to say that there's no jet going lateral to medial, and there's no jet lateral to the clip. Are you correct with it?
I agree with both of those assessments. Yes.
And now what we can do is proper 3D end phase and show that comparison. And if then it's okay, we should deploy this clip. Correct?
Do you concur?
Yeah. And we should see the pulmonary veins. But I think the MPR imaging was so helpful for this case.
Yes.
Right? I think, Gabriel, you're finally learning the whole thing.
There's a pretty good grasping view in the top right or in the right
image.
image.
You see the posterior leaflet is in. You see how the 2 leaflets are in. And it's very important to see that you can see this. And we know what a nice thing on MitraClip is that you're very relaxed. Look, we're standing over here, we're chatting, we're not doing anything, we're just watching things go because you can take your time. There's no stress. Now the LA pressure, you can see it's blunted, but this diastolic component has reduced. Do you agree with that?
Yes, yes.
And now this is the right pulmonary vein. And you can see this is actually quite nice. You see that the systolic dominance, you see the systolic phase, it was much more blunted before. It's actually
it's on its way to being co-dominant.
Yes.
Yeah.
Okay.
And then we check we don't expect a gradient since we're so lateral. But
so we go to 4 stages. We first see leaflet insertion, then we see color change, then we look at pulmonary vein flow, and then we see gradients. Now if the gradient is more than 4 or 5, then we think, wait a second, we should not deploy this clip. But here the gradient looks, it's nothing, it's very little. So that's good, actually. Great. Okay.
One.
So the minimum is 1.
So the gradient was 2 to begin with. So
Yeah.
that tells you if you've addressed some of the flow, correct?
Yes. So do you want to show?
I'm just going to come up above the clip here
Yeah, and see if
in
you
the
can
zero,
see it.
see if I can see any jets, and then
Yes.
we're just very systematic about this, right?
Yes.
There's no
and you
rush.
can see this. Look, the jet is going up vertically. When it was severe, it was going horizontally. When you see a vertical jet, if you see a horizontal jet, a wall hugging jet, it's always significant. When you see a jet going back just straight up and down, it's not.
So when I pull up above the valve, above the clip, meaning
you don't see anything.
more lateral, I don't see anything.
See that? There's nothing. And then as you go deeper inside,
There you start to see the
it's more
jets.
medial. So that means I can just put another clip there if necessary.
Yes.
All right. So we can decide that, but
But all of these are very small on their own.
Yeah.
That
So
one's probably the most significant one.
Yeah. But it's quite far away from the clip. So let's deploy this clip, okay?
I agree with you. Yes.
Okay. So everything. So the 4 things that for teaching sake is, remember I told you, leaflet insertion. We saw that very well. Color reduction by MR, pulmonary vein flow improvement, and the gradient. And then we do a 3D end face to actually show the bow tie of the valve. So he's going. Can you show the 3D?
Yes.
And he's going to show me the 3D, and then see, look, you see it's so beautiful. It's right in the corner there. We took care of it right in the corner. Normally, and that's the nice part when you're doing these commissural cases, is the orifice valve is left open. So there's no stenosis. The downside is that on the sides, they're very difficult because there are lots of cords and you can get trapped in the cords. That's why we used a narrow clip. Okay. Lisa, how are you? What happened? All right.
You're welcome.
All right. So we're going to just close this, tighten this clip up. I don't think that's a good image, but anyway, it's of no use. All right, so let's tighten the clip. So we're going to deploy the clip.
I think that actually looks pretty cool down there below the valve.
Yeah, so you want to open this up? Try to open this up.
The glass view doesn't mean anything. Yeah, right. Yeah.
Yeah, that's good. Try to open it up. Yeah. Good. And watch fluoro as you open it up. See, keep going. And it's not opening. Keep going to loose till it's loose. Very good. That's awesome. Yeah. So that means, you see that? It didn't open at all. Let me see. Yeah, you just keep going. So it's loose now. And then I go positive side of neutral. Okay. That means it's not opening. So then I take this off. Dylan, can you just hold hold this like that? Why am I holding this? Because I'm holding this because think of it, the leaflets are attached to this gripping system. If I just yank it, I'll be pulling at the leaflets. So that's why you have to be careful. Can you get the lights here? Let me just try to get this out. Okay, see that? It's just wrapped up. It's just a manual thing. I hate this part of the whole procedure. It's kind of silly. Can you get me a hemostat? Well, I'm just trying to get this knot out. Okay, it's got it. And then what you do is you hold this like this and take out each thread. And then I do like I floss it. See that? I'll do floss. And then it's dot there. It's open. Now you can just start pulling one of the threads, fluoro. See? And the clip is not opened, right? I'll keep pulling. Keep pulling. Yeah. Yeah. Keep pulling it out. So that's the lock line. Go fast. That's it. That means the lock is closed. So I tighten the lock again to make sure it's locked. And then I try to open it again. And look, it doesn't open at all. See that? So this is okay. So then we take this off. This is the pin. And I open this 5 times till I can see a groove. You see, I see a groove there. Yeah. Now do 8 times counterclockwise. Count it. You see the arrow there? Yeah. Counterclockwise. 1, 2. Yep. 5, 6, 7, and 8. Okay, and then you just pull this back, and then you see the clip is deployed. Okay, and it hasn't moved. So you want to do a check? We
Yep.
can actually come out in the meantime. There's no urgency. We can just look at this because I'm not going to do anything more. Okay.
So you just watch his deployment system.
Okay. Attach it to
Make sure the
system.
guide's across still. It is.
Okay, good.
And his clip delivery system is out.
Are you aspirating a little bit? Gentle. Okay, good. Now you see these jets vertical, so give it aspirate a little bit more. So let's look at it and see whether we need to put one clip. But I don't think I can't put a clip on the side because then it'll become stenotic. Give it back.
Yeah.
So it's a bit tricky, you know, that what do we do with this patient? Because
No. There's kind of a lot of small ones.
so let's look at the
3D.
3D.
Maybe you try to put one kind of on the lateral aspect of the valve. I don't think right next to the previous clip because there's no pathology there, but
I know.
right here there is, but
Okay, so show me the clip where it is. All the vertical jet is gone. The prolapse is actually gone. And now just can you just explain just medial to the clip? Okay. Good. Well, if there's more medially, I won't do anything because it's far away. The only question is there anything here that I need to do?
there might be a little bit of prolapse there. Do you see that?
Yeah.
Posterior?
Yeah, get color there. No, it's going up, right? It's vertically up. There's no, if it's prolapse posteriorly, it should be
Yeah,
anterior.
should go anterior. Yeah.
But it's not. Huh? It's not eccentric. Because the jet before it was horizontal. Yeah. So I actually don't know whether it'll be a benefit. I actually don't think we can do any.
Do you think his LA pressure is still better? Is still good? Better?
No, it's still high, but
But he has diastolic
to,
dysfunction, right?
Yeah. But I mean, these small jets, I don't know whether I can help them. I don't think it's going to help.
Yeah, you certainly address the eccentric jet.
Yeah, and I think that's all we can do for the time being. But this is what people try to do. They try to fix the middle valve, and then they cause the valve to become narrow, and then the LA pressure goes up. So it really doesn't.
That clip looks very stable.
And the clip looks very stable. Yeah. So I think there's no need to just give a 3D with or without color.
Okay, Pierre, what do you think, man?
Yes, exactly.
Yes.
And look at how the leaflets are coapting very nicely in the middle.
Yeah.
And look,
there's no obvious pathology here.
There's no pathology like in a flail or prolapse. And you see that they're far, and the first jet is far away from the clip.
I mean, I think if you address one part of the valve you're going to keep chasing jets.
Yeah, then you're just going to convert a normal orifice valve into a stenotic valve.
Yeah.
I don't want to do that. Yes, and you can see how beautiful it's in the corner, so you can't even see the clip. It's right in the corner. So we're just going to come out, measure the LA pressure final, and then we're going to straighten out the guide. What's his blood pressure now?
115/54.
Okay, so he was actually lower when we came in. It was in the hundreds, so the pressure went up.
It did go up about 10 points, yeah.
Exactly. So that's very good. So that's an important sign of improvement.
Good forward flow now.
Yeah. So I'm going to take the guide out, and we're actually ready to close the groin. You want to see the ASD?
Sure. I'm just trying to. I'm debating with myself. What is he left with? How much MR?
Yeah.
It's either mild to moderate. You know.
I would say it's mild to moderate for sure.
Yeah.
Okay. So I would. Can you measure this LA pressure final? And I'm going to pull it into the RA and measure the RA pressure. We're in the RA now, and the RA is still very high too. His RA is 24. Wow.
So he could be diuresed.
He can be diuresed much more.
Yeah.
So all these guys were saying that not to diaries. It doesn't make any sense. Yeah. Okay. All right. So let's just pull this out.
There's his TR.
Okay. These are very challenging cases. You want to check a ACT level first? You want to check an ACT?
He had this effusion to start with in case anybody's concerned, you know.
Yeah. It was there before. And the RB and LA are the same.
Part of our initial assessment, we always look for that kind of stuff. So, all right, very good. ASD is left to right, so nothing to address there. It's small enough.
Can you look at the aortic valve? The aortic valve is also narrow a little bit.
Yes.
You see that? His aortic valve is also narrow. Wow.
Yep.
And you want to measure that area? It's not critical, but it's definitely narrow. But it's not less than 1. See, the right coronary cusp is not calcified. The left and non-coronary are. The left is, yeah, that's right. The left is the left side. Right is in front, and the left is not correct. So you see he's measuring a valve area.
Two.
This is okay.
0.3.
You may be on a lower level, but I think it's
Yeah.
less than that. Okay, so let's go pull it back. Okay. Okay. Yeah, you're good. Yeah, it stopped already a little bit. Can I get the knot pusher? Do you want to give a little bit of protamine?
Sure.
We haven't got an ACT done, did we?
The initial one was 270. Yeah.
I think we can give a protamine because his procedure was very fast. We're actually already done. So I'm just putting one. I only use a single perclose in these cases, even though he's an obese patient. Hold the pressure, and it doesn't matter. We just do a figure of 8 stitch. Okay, let me see. Let your hand go. Okay. Have you given some protamine? Can I give?
How much do you want to give, Saibal?
Well, give 30 at least.
Okay.
Right, because we gave him a lot of 12,000 of heparin, and the procedure was only 30 minutes. Can I have a suture? I mean, the bleeding's almost stopped. Yeah. Hold pressure. So the bleeding is almost stopped, but we just
So 30 protamine, yes?
yeah. I want a big bite for this tissue. So I'm going to do a figure of 8 stitch in the subcutaneous space. Let your hand go. Good. Even though the bleeding is almost stopped, but this is an extra guarantee that I do.
Protamine going in.
I want you to focus on the groin. Yeah, it's protamine. That's why we're giving some protamine.
I gave him 30, Jose. Yeah.
Maybe you should give more, right? I mean, it's 231. It's about 200. So there's no bleeding at all.
I'll give another 20 then. Okay.
Yeah. And then we just do this. This is called a fisherman's knot. Wait a second. We want to summarize the case after this. All right. That's good. We did the blade and we're going to cut it. So before we end, we'd like to summarize this case. This was a very sick individual. As you can see, in refractory heart failure for months, readmitted with heart failure, had MR severe from a eccentric jet from P1, has moderate aortic stenosis, has diastolic heart failure, has chronic renal failure with the creatinine 2.9, who now has underwent a successful MitraClip procedure. With one MitraClip, he's left with mild to moderate MR, which is not related to the original pathology. So we think this is good. We did a transeptal from the femoral vein, and you can see we have only a single stick, no bleeding at all. We have just anesthesia, we're going to extubate. And we would like to thank everybody and thank all the members in the team over here for being so late for this case. Thank you so much. Colleen, it's the first time I said thank you to you. Okay. Thanks a lot.